Hello and welcome to Eyes on Research, the podcast that digests the latest scientific innovations in eye research using simple and understandable terms. I am your host, Thales Guimaraes, medical doctor and clinician scientist at Moorfields Eye Hospital. Hello and welcome to another episode of Eyes on Research, and today is a very special one. We have reached episode 20. What a fulfilling journey it has been for me so far. I gotta tell you the truth, receiving, even the slight feedback or comment from patients, families, healthcare professionals, and even doctors saying that this podcast has helped them in one way or another has been nothing short of amazing. So thank you so much for that. I hope we can always continue to provide great and reliable information for you. But I digress. Let's start this week's episode, which is all about Stargardt disease. We'll be providing some basic concepts. We'll be talking about the symptoms, and then we'll discuss the avenues of treatment that have been or are currently being explored. But what is Stargardt disease, right? And this is a form of inherited retinal dystrophy that presents in the first 2 decades of life, but frequently more commonly during childhood, even before 10 years of age in most cases. The person who discovered Stargardt disease was a German ophthalmologist named Karl Stargardt, and it was first reported by him in 1901, more than a century ago. It has a prevalence of around 1 to 8 in 10,000 individuals, making it the most prevalent cause of inherited visual loss in kids. It affects the retina, which is this film like tissue that we have in the back of our eyes that has many millions of light sensitive cells. And these are called photoreceptors and they are essential for vision. This is a disease that follows a specific pattern of inheritance, right, from parents to offspring. We call it an autosomal recessive disease, meaning that the usual way that a child gets this is by having two parents carrying a mutation in this gene, and they do not have any disease. They do not have Stargardt disease because they still have one healthy gene, and passing this to their children, right? When the children in the situation where they get a double dose of a mutation, right, the one from the father and the one from the mother, in this gene that we call ABCA4, they get Stargardt disease. Now, this is a gene that's located in the membrane of photoreceptors, something that we call a transmembrane protein, and it's called a flippase because it works as an elevator, right? That removes toxic byproducts from the normal cycle of vision from within the photoreceptors. These are mostly derived from vitamin A, which is the crucial element in the visual cycle. So the gene ABCA4 makes the protein of the same name that cleans up all the fatty material that's left over. When the gene is not working properly, this material builds up, killing the photoreceptors and reducing the central vision in the long run. Right? This is a chronic damage. Now, there are other genes that have been identified as causative for Stargardt disease, right? Such as ELOVL4 and PRON1. But these are much rarer causes and they follow a different type of inheritance. The inheritance pattern from these two genes is an autosomal dominant inheritance pattern, meaning that one copy of a mutation is enough to have the disease. But these cases are almost the exception. They are very much rarer than the ABCA4 cases. In fact, ABCA4 is the most common gene associated with any form of inherited retinal disease. So, most of the things that will follow in this episode from here onwards are still much applicable to all of these genes, okay? So, even though the most common one is ABCA4, all of the things that are coming, save some, of course, exceptions, are still applicable to all of these genes. So, what are the symptoms of Stargardt disease? And regardless of the gene, the symptoms are going to be very similar. There are cases where patients may get a disease that start in late adulthood, right? But it's typically a childhood, a juvenile onset disease with a relatively slow progression in most cases. It causes bilateral progressive central vision loss, and most commonly, patients do have an intact side vision, right? Peripheral vision. So they don't typically have difficulties to navigate the environments, right? Because they can see well their surroundings. But there are certain mutations in the ABCA4 gene that have been associated with a much more severe phenotype. The most severe one also affecting the sides of the visual field and the ability to see at night or in dim lit environments. Patients may also have some gray or hazy spots in the center of the vision, difficulties with color vision, and an increased sensitivity to light, what we typically call, as ophthalmologists, photophobia. Now, of course, some of these things will change depending on the mutation, on where in the gene the mutation is, because if you have a mutation that's a little bit more severe or in a part of the gene which has a specific function, and it's highly conserved through evolution, and it's something important that the gene does, it's a site in the protein that's really important, then you may have something a little bit more severe than the typical and classic Stargardt disease reported by Carl Stargardt. Typically, the diagnosis of Stargardt follows a common history of failing in a vision screening test or some school concerns with, some teacher may reach out to the parents and have concerns with a child's vision, and this will prompt a referral to a more specialized service. There are multiple forms of tests can be done. Some that can measure the electrical activity from the eye to the brain, as well as some forms of imaging in the back of the eyes. Right, we have several images, that types of images, the modalities of images that we use, from 3D scans of the retina to straight on pictures of the retina. Some of these pictures actually we use a specific filter. It's a blue filter that lights up pigments in the back of the eye, and it's one that the patients always remember because it's the most uncomfortable one because of the flash. It's a bright flash. If whoever done it, you know what I'm talking about. But it's very important. So make sure your physician can get good images, because in turn this will help you as well. This is usually followed by, after the electrical activity test, it's usually followed by a genetic testing, which, provides the final diagnosis of the condition and show us where the mutation is. I would say, if you're interested in hearing directly from a family affected with Stargardt disease and listening to their journey, you should listen to our podcast episode on family support groups. My guest was Bhavna Taylor, a lovely person who is the CEO of Stargardt's Connected. It's a family support group and a funder of research in Stargardt disease. Huge shout outs to the Stargardt's Connected family, by the way. I'll leave their website in the description of this episode in case you want to go give them a visit and see the amazing work that they are doing. Treatment wise, unfortunately, there's no specific treatment, right? At the moment, as of May 2024. There are some treatments that have been attempted, while others are in a clinical trial stage. And we'll talk about this more soon. However, one important mention here is that not having a specific form of treatment is completely different than not doing anything at all, right? And we have been treating our patients as physicians for many, many years. This is not new. Things that we usually recommend are things that have been shown at some point in a research study to be protective for the retina, right? For instance, protecting your eyes from UV radiation coming from sunlight. And you can protect yourself with hat and sunglasses when you go outside. That's the easiest way to do this. And by the way, We have an episode on types of damage that can be induced by the sun. So feel free to check that out if you want to know more. We also recommend refrain from, smoking, to refrain from smoking, as there is research suggesting that this may slow down vision loss in people with Stargardt, right? And in other forms of macular disease, for that matter, such as age-related macular degeneration, which again, we have an episode released just a couple of weeks ago where we talked all about age-related macular degeneration. So feel free to check it out if that interests you. And the last thing that I would say that we recommend to patients, actually two more. One of them is making sure that patients have a healthy eating habit. So, eating plenty of green leaves, and also plenty of fish, because we know that those things carry some substances, some molecules that may be important and may protect your retina against oxidative damage. And also, the last thing that I should say is that most of the forms of inherited retinal disease, it doesn't matter if it's a rod cone dystrophy, it doesn't matter if it's cone rod dystrophy, Stargardt disease, doesn't matter if it's Leber congenital amaurosis, if it's early onset retinal dystrophy, if it's something stationary, right, like congenital stationary night blindness or diseases like achromatopsia. Most of these will be associated with refractive errors, meaning that some will be associated with short sightedness, some will be associated with farsightedness or astigmatism. So it's very important to give patients the optimal vision that they can have with glasses or contact lenses. So it's very important to make sure that the prescription is up to date, right? So there I spoke about four things that we can do right now to help patients, right? Although these are not specific, they certainly change and give the patients a better quality of life. But let's go back to specific treatments. There have been indeed some clinical trials in the past using different techniques, and some are still ongoing, right? From gene therapy to stem cell therapies, as well as oral drugs. Some of those, of course, were in animal models, but some of those were also tested in humans, right? So let's talk about oral drugs first. In one way or another, the the most common target of the visual cycle for these drugs is vitamin A, of course, right? Remember that the main idea is to try and reduce the amount of toxic waste within the retina, reducing the speed of progression or halting it altogether, right? So, of course, you would target vitamin A because that's the crucial step. That's the crucial substract in the vision, in the cycle of vision, right? It's a very important molecule. Drugs like emisoxatat, which is a visual cycle modulator, as well as the ALK001 deuterated vitamin A, which is essentially a modified form of vitamin A, have been used in clinical trials. While the data suggests that these drugs are highly tolerated, there are very little signs of efficacy. Another drug being used currently with results highly anticipated is a drug named tinlarebant, which is being used in the Dragon trial, right? It's a clinical trial for Stargardt disease, and a similar drug, actually the same drug, is being used for age-related macular degeneration as well. And there are some other dietary approaches too, right? Like using omega-3 fat acids, right? And saffron supplementation, right? Which seems to have retinal neuroprotective effects against oxidative damage. You've heard that, right? Saffron, right? The spice. Now, although there were no safety concerns in any of these trials, there were also no signs or no significant signs of efficacy. Now, regarding gene therapy, if you've listened to our gene therapy episode, you will remember that for gene therapy to be successful, the information, the gene that you're trying to deliver needs to reach the nucleus of the cells. And therefore, a vessel, or as we call it, a vector, needs to carry this information inside the cells. We typically use viral vectors for most gene therapies in the retina. However, the size of the gene may also be a limitation because of the small size or the packaging capability of the most used type of of vector, which is a virus named adeno-associated viruses, right? So we use what we call AAV in short, which is adeno-associated viral vectors. So although Stargardt disease would in theory be a good candidate for gene therapy, the large size of the gene hampers our ability to do this right now. Although there are many labs researching different types of vectors. One possibility, for example, is the use of dual vector strategies, which employ mechanisms for the formation of a single complete therapeutic compound from two different vectors. This technology has been used in some animal models of the disease, and I guess the collective conclusion seems to be that, albeit it will certainly be less efficient than employing only a single vector, given the current limitations we are facing with vector technology that we currently use, it seems that dual vector may be indeed an interesting alternative for clinical trials. Nanoparticles have also been attempted in some studies as an alternative for viruses, and I'm a huge fan of nanoparticles. In some working mice, there were no signs of toxicity, and there was indeed a demonstrable reduction in the amount of toxic buildup within the mice retinas. So it seems to be another promising approach. Another gene therapy based approach is with the use of antisense oligonucleotides, which are small particles that can be used to target specific mutations on a gene. These are incredibly promising molecules that are being used for some diseases. To date, this has yet to be attempted in human clinical trials for Stargardt disease. Now, another limitation for gene therapy, and this you may have heard from your doctor in case you have a family member with Stargardt disease, is that Stargardt may not be the best target for gene therapy. The reason for that is that for gene therapy to work, the cells need to be structurally preserved for the viruses to have something to infect. When there's a large area of scarring, or as we call atrophy, right, the cells are essentially non existent, making gene therapy unlikely to show any benefit, which is when you want to proceed to something else, right? For example, stem cell. This is because in stem cell therapies, you are essentially supplementing new cells that have been genetically modified to serve its function. We have a full episode on stem cell that was just released 2 weeks ago, so you may want to check it out. Promising data coming from testing in animals led to human clinical trials, and there were indeed a few trials using stem cell derived from different sources, from embryonic stem cells to bone marrow derived stem cells. Only a few patients were enrolled in these trials, but apparently no adverse events were noted, right? Which is huge. However, efficacy signs were also quite limited. There were indeed some patients that regained vision in the eye that was treated compared to the eyes that were not treated, but that is not enough. You need to compare this for regulatory purposes. You need to compare this with patients that did not have a treatment. But it's good because this is an early sign that something is going on after you put that something improved. And again, we have an episode from last year on the phases of drug development, so go check it out. This will make a little bit more sense. There are other trials using a similar technology, but they did not show any improvements in vision. So stem cell is very promising. I think we the past decade or so, we were we are still living the era of gene therapy. There's an explosion in the number of gene therapies, right? For all types of indications that you can imagine, from Parkinson's disease to Alzheimer's disease to Duchenne muscular dystrophy, all the way to retinal diseases, right? Uh, Stem cell is still to come. So I think we are still in very early days regarding stem cell. But yes, I think it's very promising. Finally, the last technology that I'll just be touching the surface today is CRISPR-Cas9. This is a type of procedure that we call gene editing, and it is derived from an extremely effective defensive system that the bacteria developed in their lifelong fight, war. with viruses. Essentially, a piece of the genome is cut and another is joined in its place. And of course, we expect to cut the piece of genome that has a mutation, right? And to join a healthy copy of the gene sequence in that specific part that you have cut. No clinical trial, though, has used this technology in Stargardt, but this remains an incredibly exciting alternative for the future. I aim to also have an episode on CRISPR-Cas in the near future, so keep posted. As I always say, research is a marathon as opposed to a sprint, and things will eventually happen. Due to the commonality of Stargardt disease, there are many research groups looking at possible avenues for treatments. Similarly, plenty of biopharmaceutical companies are looking to treat this condition. Keep posted as we will provide all updates as they become available. In case you didn't know, we have a website where we post articles weekly, which is linked in the description. Feel free to check it out as many of these research updates are posted there. Thank you so much for listening to us today. I should also say that we have social media accounts where we post short videos about teams that did not go on to become a full episode. So visit us on at Eyes on Research on your favorite social media, Twitter, TikTok, Instagram, LinkedIn. We have it all. Go search for us. Also, as I just said, you find the link in the description of this episode to our Buy Me a Coffee website, which is the website that we use to post our articles. Now, please consider subscribing to us there. It's completely free, and we are using that platform as a blog. So you see weekly articles about curiosities and trivia about the eyes and vision, as well as hot research updates on topics that did not go on to become a full episode, such as, for example, an update on a treatment for Stargardt disease. So please do consider subscribing. You need to click the three dots in the top right corner of the website, provide your email, and hit follow. I can guarantee you won't receive any spam as I send the emails myself. Our mission here is making science more accessible to the population, so it's free and always will be. However, we are completely self funded as well. So if you have the means to, you can certainly donate in our Buy Me a Coffee website, which, although very optional, is highly appreciated. And you get access to special posts, episode transcripts, and very cool things, right? Like, for instance, suggesting themes for blog posts, short videos, or even full episodes. Anything that piques your interest, so please consider checking that out by clicking the link in the description of this episode. Otherwise, share the podcast widely amongst your friends and families and make sure to give us a rating if you like what we do. This also helps us a lot. Thank you very much, and I'll see you in next week's episode. Have a nice week.